I'm starting the timer, and here is your question. Okay, so if you have read and understood, kindly begin your examination station.
Yes, I am ready. I will start. I will start by wash my hands. Good morning, I'm Mr. Al-Ghaziri, one of surgical doctors here. Can I confirm your name and age, please?
I'm Tom, 49 years old.
Nice to meet you, sir. Today I'm going to examine your balance. It
Yes.
will include asking you to walk, check your hands, and some examination, some
Yes.
tests for your legs. Do you agree with this?
Yes.
Okay. Do you have any pain at the moment?
No.
Okay. So keep with your chart, please. And if you don't mind, can you take a few steps to the wall of the room, please?
Okay.
Then turn and come with your heel, two toes, one in front of the other, as a tandem gait.
Okay.
Now I check for ataxic gait or cerebellar ataxia, wide base gait. Then, if you don't mind, can you stand for me now?
Okay.
And you will close your eyes, and I will test your steady. I will put one hand in front of you, and
Okay.
the another one behind you to support you if you feel unsteadiness. Okay.
Yes.
So now, after that, can you take a seat on the couch, please? Now, can you say, please, a British Constitution?
Okay.
Then, please keep your head still and follow my finger moving in front of you with your eyes. I will check in nystagmus, the site and the pattern of nystagmus. I was moving my finger from side to side. And then after that, I will ask the patient to touch. Can you touch with your index finger, my right index finger, please? Then touch your tip nose. Then make it as quick as you can. Then I will test also with your left hand, touch my left index finger. Then touch your tip of nose. Then as much quick as you can with moving my finger. Then after that, I will ask, can you please pick or touch this pencil or pen to detect any intention tremors? Then after that, can you please, with your closed eyes, can you straighten your hands in front of you with your palm facing the floor to detect? And now I will push against your hand suddenly, and I will protect with your face with my other hand to detect the rebound, pronator rebound. Then after that, I will ask the patient to straighten the hand with the palm to the face to detect any pronator drift. After that, I will ask the patient, please make your hand and arm is floppy. I will test. If you feel any pain, let me know. I will bend your elbow and straighten it. Move your forearm inward and outward to detect any hypotonia. Then after that, can you please put your hands over the other one, then turn it to face the palm to the other palm, and to do it as quick as you can to detect any diadokinesia.
Good.
Then now, please, with you are sitting, can you expose your thigh or legs? Now I will tap in your knees. If you feel any pain, let me know. This is to detect the knee reflex, and I will see for contraction of quadriceps muscle, comparing with the other side. Then I will ask, please, if you don't mind, can you lay down on the couch? Then I will test the your legs by leg roll and lift to detect. I will take your knees to detect the tone of the lower limb. Then, if you don't mind,
Yes, how would you
can you
confirm? How would you
what?
confirm the leg roll?
How you what?
How would you do the leg roll and leg lift?
Leg roll. I will roll the at the knee joint with my hand. Then I will see the foot
Yes,
moving away from the movement of the knee.
yes,
Then, according to the leg lift, I will ask the patient, please, I will take the weight of your knees. Then
yes,
I will keep it lift off to the bed, and asking and seeing there is hypotonia or hypertonia.
yes,
Then, please, if you don't mind, can you put the right heel uh, uh, over the left knee, then run along the leg of your left leg, then lift off, then put again on the knee, then move as quick as you can to detect heel knee coordination.
good.
So if you now I will test some nerves supplying your head and your neck. Please, if you don't mind, can you give me a cough?
Okay.
Um, can you open your mouth and say ah? Can you take a sip of water, hold it in your mouth, and can you swallow again now? Then
Okay.
can you shrug your shoulder? Don't let me to push it. Turn your head to other side and don't let me to push it.
Good.
Then can you stick your tongue out, please? Then push with your tongue
Okay.
against my hand.
Your bell
Thank you.
went. Can you please present your case now?
Yes, thank you for your time. I will pass my
Good.
consultants to figure out your issue. Today I examined Mr. Tom, 49-year-old, who
Good.
presented with a history of psychiatric disorder.
Yes.
On examination, the patient has ataxic gait with this kinesia,
Yes.
with nystagmus and staccato speech, with hypotonia, otherwise normal reflex.
Yes.
So my top with intention tremors. So my top differential diagnosis is
Yes.
cerebellar ataxia,
Good.
mostly due to posterior cranial fossa, but
Good.
I will consider the other causes in form of head trauma, transient ischemic attack, and also multiple sclerosis,
Good.
and other metastatic tumor to the
So
cerebellum or
what
posterior cranial fossa.
investigations would you do to confirm your
So,
diagnosis?
as regards the most important, I will start. Can I do X-ray to detect any calcification?
Good.
CT, but the most important is MRI with gadolinium due to enhancement. CT is
Okay.
inferior due to artifact from sick bone, but CT is useful in follow-up of the patient. CT whole of the body to detect any primary origin of the test of malignancy if the cause is metastatic disease.
Yes.
Otherwise, I will do also stereotactic biopsy,
Yes.
and will discuss the patient in MDT team,
MDT.
including
Good.
neuro-oncology
Yes.
for
So
surgical
what
excision
treatment
of
would
the.
you offer to the patient?
After discussion in neuro MDT team,
Yes.
I will offer the patient upon which I will discuss in form of surgical excision of the
Very
tumor
good.
or debulking.
Very good. So can
Yes.
you tell me, please, a few posterior fossa tumors that you might consider?
Yes. As regard the tumor, may be metastatic
Yes.
from lung or breast, and may be primary in
Primary.
form of
Very good.
hemangioblastoma,
Very good.
ependymoma,
Yes.
ependymoblastoma, desmoid tumor, neuroectodermal tumor, and brainstem glioma, choroid plexus papilloma.
Yes. Very
Uh,
good.
yes.
Thank you so much.
Thank you.
Thank you. Yes. Anyone want to give feedback to Dr. Mohammed? It was very good. I think you covered everything. I just want you to remind you that once you're explaining to me, and you will be doing it on patient will be there, and examiner will be noticing you. So you have to do it on both sides.
Yes.
Yes. And
Yes.
now that you are telling me, so you say you'll perform it on both sides, both legs,
Yes.
both knees,
Yes.
both ankle examination. So it's not
Yes.
that, yes, I understand you're doing it right, but you have to especially mention it. So I know that you know that you're doing it on both sides, not just one perspective.
Yes.
So very
Yes.
good. Yes.
Yes.
Anyone
Thank
else
you.
want to add anything? Any comment? Is there anything that you would want to do to complete your examination in this session? If time would have allowed you?
What, ma'am? What is the question, please, ma'am?
Yes, if time would have allowed you, would there be any examination that you would do to complete your examination? Any clinical?
Upper and
Yes.
lower neurological examination.
Yes. Yes.
Upper
So
limb.
when when I asked you to present your case, before you told me differential diagnosis, you can say this, that if time would have allowed, I would have done this to complete my examination. Right.
Yes. Yes. Yes.
Thank you. Good. Yes.
Thank you. Thank you.
Starting the timer, and here is your question. Right. So if you have read and understood, considering it critical care scenario, please tell me, how would you manage this patient?
Yes, I will manage these patients according to the critical care of surgical patient protocol
Yes.
by maintaining patent airway, proper breathing, and adequate circulations. In view of the previous fluid challenge, I will do more fluid challenge and monitor the response of the patient.
Yes.
I will repeat the fluid challenge 4 times and inform my consultant.
Okay. So how do you plan to manage the fluid management? Can you discuss the fluid chart? Because patient was given 2 times 250 bolus.
Yes, I will
ml
give.
bolus.
Yes, I will give him a 500 milliliter
Okay.
crystalloid over 30 minutes, and then monitor the fluid response and also correct
How
the
frequently are you going to monitor the response?
by the urine output.
Yes, how frequently?
How frequently?
Yes,
Every hour.
Every hour. Very good. Okay. What is the formula that you are going to follow for the fluid challenge?
500 milliliter crystalloid over 30 minutes.
Okay. And then if patient does not respond, how what would you do next?
I will notify my consultant.
Yes, meanwhile consultant is coming, what would you do? Because at this time at 2 a.m. patient's blood pressure is 70/30. So while you're waiting for your consultant, what measures would you do?
I will give the patient inotropic support to increase the cardiac output, and also vasopressor agent to increase the systemic vascular resistance.
Okay, so what would you give for as an inotropic support?
Examples?
Yes, yes, please. What example would you give?
Inotropics like adrenaline, epinephrine, and norepinephrine.
Okay, so you'll read what are the inotropes which increases the preload and what decreases or increases the afterload, and which one would you be using and why? So what your aim is in this situation, when blood pressure is low, and patient is
Yes.
post-operative. So what's happening? Do you need to improve the cardiac output?
Yes.
Yes.
I
So what
give
is the formula for cardiac output?
cardiac output equal heart rate multiplies the stroke volume, and the blood pressure is cardiac output multiplies systemic vascular resistance.
Good. Okay. So can you tell me what are the options to monitor the fluid balance status?
Yes, by the detecting the by urine output, detecting and also the capillary fill time, cardiac index like central venous pressure and capillary fill time,
Yes.
and peripheral warmth, um,
Okay.
and the blood central
Yes.
venous pressure.
Yes. Can you please tell me what is the normal or the most common fluid choice of fluid to give?
What's the most common
Choice of fluid to give to the patient in post-operative condition?
Trace of fluid? What is the trace?
Choice of fluid. Are you going to give normal saline or Hartmann solution? This was my
No,
question.
Hartmann.
Why? What is the difference? Why Hartmann is better than normal saline?
To avoid because Hartmann is to avoid hypertension if the patient's or to avoid hypernatremia with normal saline.
Okay. What are the contents of normal saline? How much sodium, how much chloride does a normal saline contains?
No, boss.
Okay. Can you please tell me what is the purpose of fluid therapy? What are you trying to accomplish by giving fluid to the patient?
Please again, what is the E?
What is the purpose of giving fluid therapy? What is the aim? What are you trying to accomplish by giving fluid therapy?
Yes, because the fluid therapy is both is diagnostic and therapeutic.
Very good.
And this
To replace what? The electrolytes and yes.
Yes, replace electrolytes and improves and elevates the central venous pressure.
Okay. Do you think patient is in shock? If yes, then what type of shock is in patient?
Is the patient? Yes, the patient is in distributive shock.
Okay. So can you please tell me which fluid is good to give as a maintenance?
As a maintenance?
Yes, maintenance fluid. Which fluid type is good to use as a maintenance fluid?
Crystalloid.
No, normal saline with potassium or Hartmann solution, you already know. Okay, can you please tell me what are the factors which determine how much fluid should be given to the patient?
Factors which determine how much fluid?
Yes, patient needs.
According to the according to the blood pressure of the patient and the clinical status of the patient and the urine output.
Yes, if there are already ongoing losses and if patient has any pre-existing fluid deficit, then you'll decide, okay, already patient is losing fluid, so you will give more. So can you please tell me, when you are increasing the maintenance fluid, so what are the conditions you'll keep in your mind?
If there is increasing the maintenance, yes. If there is
patient has fever, what else?
If there is another problem like hemorrhage, like occult hemorrhage.
If there is ileus, if there is vomiting, if there is stoma formation or fistula or pancreatitis, then you'll decide or you'll determine. Okay, can you tell me, all right, okay. In this patient, how would you maintain, this is the post-op patient, how would you maintain the nutritional requirement?
Nutritional requirement. The patient with I will give enteral feeding. There is no problem. There is no
Okay.
there is no contraindication. There is no contraindication to enteral feeding. So I will maintain enteral feeding.
Okay. What is the basic requirement of water for an adult patient?
Of water
Yes, please.
for adult?
Yes, adult patient.
No, but both I don't know.
Okay, 30 to 40 ml per kg per day. This is the average amount. Okay, can you please tell me the contents of Hartmann solution? How much chloride, how much bicarbonate, and how much sodium and potassium?
No, I don't know both.
Okay, what is the osmolality of Hartmann solution or ringer lactate?
Osmolarity?
Osmolality.
How much?
Yes, how much is it? What should be your aim in the post-op patient to keep the optimal osmolality? Urine has an osmolality, okay? So you are giving fluid, you're putting something in, patient is passing urine. So how much osmolality would the urine be? Then you'll think, okay, it's all right. It's within the limit. It's within the range. You read this all, okay?
Okay.
So thank you.
But this is all new questions.
So it's timer has started, and here is your question. Right. If you have read and understood,
Yes, I'm ready.
considering it surgical anatomy station, please tell me this. All right, this red triangle is what? Can you identify it?
Yes, the red triangle is anatomical snuff box.
Good. Can you tell me the boundaries of anatomical snuff box, please?
Yes, there is boundaries anterolateral and the posteromedial. Posteromedial will be extensor pollicis longus, and the anterolateral will be extensor pollicis brevis and abductor pollicis longus.
Very good.
And as regards the floor is
Yes.
scaphoid bone,
Yes.
and in the roof will be cephalic vein, and the content will include radial artery.
Okay. Right.
Yes.
Good. This green triangle represents the area of supply. So this area is supplied.
Sensory supply of the radial
Yes.
nerve. Yes.
All right, good, good. Okay, can you please tell me if in this patient acquires, for example, anatomical snuff box injury, so how would patient present?
Anatomical snuff anatomical snuff box injury.
Or there is
will be
scaphoid bone.
fracture.
Yes.
Will be fracture of the scaphoid bone, maybe
Yes.
lead to avascular necrosis due
Yes.
to the proximal part, due to deficient of the blood
Yes.
supply of this area away from the middle and distal area.
Okay. So why there is avascular necrosis when there is a fracture of scaphoid bone?
As the blood supply is demonstrated by the lateral and dorsal branches from the radial artery in form of palmar and the dorsal arteries supplying the middle and the distal part. Otherwise, the proximal part is depend on only in the retrograde flow of blood supply of middle and distal.
Okay, can you please tell me what are the movements which are present at the thumb?
Movements of the thumb, abduction,
Yes, please.
abduction, 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 flexion, extension, opponents.
Opposition. Okay. Can you tell me
Oppositions.
all the muscles which are responsible for opposition of the thumb?
Opposition of the thumb. Opponents polishes.
Yes. Two others.
Sublight by median nerve.
Yes.
And
Two others.
flexor
Flexor pollicis brevis and abductor pollicis brevis.
pollicis brevis. Yes.
Yes. Yes. Yes. Okay. Right. Can you tell me what are the muscles which form a thinner eminence?
Flexor pollicis brevis, abductor pollicis brevis, and opponents pollicis.
And okay. Can you
Adductor
tell
and
me? Yes.
adductor
Yes.
pollicis.
Adductor.
Adductor
Okay.
pollicis,
Can
yes.
you please tell me what are their nerve supply?
Nerve supply of the median nerve.
No,
The recurrent
thinner
branch.
eminence. Yes.
Thinner eminence, yes. Recurrent branch of the median nerve. Thinner
And?
eminence.
Yes, and flexor pollicis brevis,
Flexor
superficial
pollicis
head and the
abductor
deep
by
head.
median nerve.
Yes, and the deep
Adductor,
head.
adductor by ulnar.
Okay, cool.
Adductor pollicis by ulnar.
All right. This X-ray was done for this patient. Just say it's
Yes.
from this book. So, can you tell me what you see here in picture on the left side upper? It shows
This
A
is scaphoid bone.
and B.
This is the head of radius or styloid process of the radius.
Okay. Okay. And then
Yes.
C here is showing what?
This is showing the first metacarpal bone.
All right. D is showing what? Which bone? Okay, and E is showing what?
Styloid process of the ulna.
Ulna. Okay. If a patient has an injury at the wrist, so what clinical features do you expect to see on the patient?
Wrist injury.
Yes, at the wrist. If patient has
Yes.
injury at the wrist, so what features or what clinical features do you expect to see on the patient?
Maybe bone fracture, maybe nerve injury. As regards the nerve injury, maybe
Yes. It will
as
result
regard-
in clawing of fourth and fifth digit, and then loss of sensation of medial 1.5 fingers of palmar or dorsal aspect.
yes, this is as regard the ulnar nerve. Yes, medial 1.5,
Yes.
ulnar 1.5, and the medial third of the palm, and the palmar surface and dorsal surface of the both
Okay,
the hand and the finger.
What do you understand by the term ulnar nerve palsy?
Ulnar nerve palsy.
Yes, please.
Paradox.
Yes.
Paradox or palsy.
Palsy.
Palsy. Ulnar nerve palsy will include loss of sensation,
And?
claw hand, including the partial claw hand or complete claw hand.
Yes, there'll be extension of
According
MCP and flexion of
Yes,
IPG. Yes.
extension of metacarpopharyngeal and flexion of interpharyngeal joint.
And there'll be flat hypothenor eminence.
Below hypothenor muscle, yes.
All right. Can you please tell me the attachment of flexor retinaculum, please?
The flexor retinaculum attached
Yes.
proximal and distal. As regards the proximal, from the radial side, the scaphoid bone,
Yes.
to the pisiform, and distally from the trapezium
Yes.
to the hamate, hook of hamate.
Okay, can you please tell me what are the structures which pass through the flexor retinaculum or below the flexor retinaculum?
Yes, a four tendon of flexor digitorum profundus, four tendon.
Yes.
Of flexor digitorum superficialis, median nerve,
Yes.
flexor pollicis longus.
Okay. In which conditions there can be or what do you understand by the term carpal tunnel syndrome?
Carpal tunnel syndrome is entrapment of median nerve under
Yes.
the flexor retinaculum.
Yes.
Will be presented by the numbness or tingling
Good.
along the distribution of median nerve, including the radial 2/3 of the palmar aspect of the hand, and
Yes.
the radial 3.5 fingers, including the palmar surface and only the dorsal surface of the digits of radial 3.5 fingers of
This
the
is seen
thumb,
in what
index, and
conditions?
the ring.
Yes.
What?
In what conditions? Can you name few conditions in which
Yes,
the
female,
patient presents with?
obese, wide high BMI, amyloidosis, tenosynovitis, acromegaly, hypothyroidism, amyloidosis, renal
Diabetes,
failure,
rheumatism.
diabetes, yes,
Yes.
rheumatoid arthritis, and so on. Yes, and
Okay. What
basic
should be,
lesion fracture.
yes, what should
Yes.
be the management that you can offer to the patient?
According to the nerve conduction EMG, according to the entrapment severity, I will offer the patient is splintage at least 3 weeks at the
Yes.
night, and may need the neurotonics, adjust blood glucose if there is diabetic, and the intra-retinacular injection. And if severe case of failure of management, I will go for surgical release or division of the carpal tunnel or flexor retinaculum.
Very good. If
Yeah.
a patient comes to you with a weak grip, okay, so can you
Yes.
please tell me which nerve would you suspect to be injured?
A weak grip.
Yes.
Good hand grip usually in the extension, so the wrist extensor will be affected, radial nerve.
Very good. Excellent.
Yeah. Yeah.
Yes. Good. Yes. Your anatomy concept is good. So, yes. Started your timer, and here is your question.
Okay.
Please open. Right. So if you have read and understood, considering the critical care scenario, kindly tell me, how would you manage this patient?
Yes, I will manage these patients according to the critical care surgical air patient protocol by maintaining patent airway, proper breathing, adequate circulations. I will ensure the good oxygenation to the patients by humidified oxygen. I will ensure adequate ventilations by either invasive or non-invasive ventilations, like invasive, like by intubations or SBAB, continuous positive airway pressure. And then I will manage the underlying cause, which is morphine toxicity. I will give antagonist to morphine antagonist naloxone.
How much would you give?
Yes, I will give 0.4 to 2 milligram intravenous.
Yes.
Initially, then repeat every 2 to 3 minutes until a maximum dose of 10 milligram.
Good. What are the side effects that you should look out for when giving naloxone?
Yes, nausea and vomiting and tachycardia and sweating and abdominal cramps.
Okay.
And pulmonary edema.
Good. Where are you going to manage this patient?
I will manage this patient in the intensive therapy unit, ITU, because due to the need for mechanical and the non-mechanical ventilation.
Good. Okay. Right. Can you please tell me what do you expect has happened to the patient?
Yes, there is the patient has type 2 respiratory failure as a result of the act of the morphine.
Yes.
Overdose of the morphine, which bind to the mu-receptors in the respiratory center in the medulla, causing respiratory depression.
How would you differentiate type 2 respiratory failure from type 1 respiratory failure?
Type 2 respiratory failure, there is hypercapnia, And
Okay.
in type 1, there is normocapnia. Type 1 is caused by there is inflammatory causes like pneumonia.
Oh, good.
And acute respiratory distress syndrome. There will be hypoxia and the normal CO2, and there is
Okay.
will be ventilation perfusion mismatch. While type 2, there will be like obstructive causes or respiratory depressions causing decreased outlet of CO2 and over accumulation of CO2 causing hyperkerbia.
Can you please explain the mechanism by which carbon dioxide is retained in respiratory failure?
Mechanism, how it's written?
Yes, it's written. How, yes, how in type 2 respiratory failure, how body retains carbon dioxide instead
because
of, yes.
it retained instead of chloride.
Yes, instead of, yes,
Chloride
bicarbonate, yes.
and bicarbonate.
How water combines
Yes.
with carbon dioxide in the presence of which enzyme?
Yes, the H2O
Carbonic, Ca,
in the presence of carbonic anhydrase, H2O
yes,
plus CO2
yes,
will be
yes.
bicarbonate, and the
This,
bicarbonate is
yes,
dissolved inside the RBCs, giving hydrogen and
very good. You know it. Yes.
Yes.
So all this mechanism is taking place where?
Yes, in the RBCs.
Red blood cells. Very good, very good. So please tell me how this carbon dioxide is transported in the blood.
Like the equations I have told, it transfers
Very good. Yes.
70% in the form of bicarbonate.
Very good.
And by binding to the hemoglobin to the globin portion of the hemoglobin,
yes,
forming the carboamino group, and also dissolved CO2 at 10%.
Very good. So if carbon dioxide level increases in the body, how body senses hypercarbia? Where are the sensors in the body?
How body senses hypercarbia?
Yes, please.
By kidney.
No, chemoreceptors.
Yes.
Where are they located?
Chemoreceptors in the
central,
medulla.
close to, yes,
medulla.
Okay. Can you please tell me what is the response mechanism of the body to hypercarbia?
There will be a response of the body. There will be metabolic response, but it takes but there will be delayed, but it is a delayed response.
First, it will be respiratory response. How would it talk? Yes, revolution to carbon dioxide, it leads to central acidosis. Then what happens? This stimulates central chemoreceptors. That increases what?
Increase the ventilation.
Yes, respiratory rate.
Respiratory rate to get the CO2 out.
Very good. So what is the normal PCO2 level?
Normal PCO2 no bus.
Okay, what are the causes of respiratory acidosis?
Causes of respiratory acidosis?
Yes, please.
Yes, like pneumonia. Examples: pneumonia, acute respiratory distress syndrome.
Okay.
Pneumothorax,
etc. You'll remember. Just learn 3, 4. Okay. Can you please tell me where metabolic compensation takes place?
In the kidney.
Okay. All right. Can you please tell me? All right. You already told me morphine receptors. How does morphine binds to its receptors?
By binding to the mu receptors.
Mu receptors, yes.
In the respiratory center.
Where these receptors are located?
Medulla, in the medulla.
Yes, good. In central. Okay. Right. All right. Can you please tell me if you have heard of the term chloride shift?
Yes, chloride shift is the chloride diffuse into the red cells
Yes.
to maintain the cellular balance
Okay.
in response of the diffuse of bicarbonate out of the cells.
All right. Can you tell me what is the normal bicarbonate level?
No, boss.
Okay. How is it maintained? There are 2 steps. You can learn that.
Maintained, yes, the bicarbonate is maintained by firstly by the cellular buffering response.
Very
They
good.
increase the cellular buffering response, and also leading to absorption of bicarb, and also metabolic by increase the renal absorption of bicarb.
Very good. Good. Question pending. Right. Nice.
Okay. Should I know the normal